Pneumothorax is a term used when the air is present in the pleural space, which often causes collapse of the adjacent lung. Prompt identification may be critical, and bedside ultrasound may be particularly useful as it's both quick and highly sensitive. When assessing for a pneumothorax, use a high-frequency linear transducer and start by placing the transducer in the mid-clavicular line, somewhere between the second and fourth intercostal space, and make sure that the probe is perpendicular to the chest wall. Now we look for a landmark to orientate ourselves. Find the ribs that appear as a hyperechoic structure and with a rib shadow. Between them there's a muscular layer, and directly below you should see a hyperechoic line, which is the pleura. This line should be both the parietal and visceral pleura, but you can't differentiate between them. In a normal individual, the visceral and parietal pleuras are sliding, and this is termed lung sliding. In addition, we may notice A or B lines. A lines are reverberation artifacts from the pleuro-pulmonary interface, and these can be seen in healthy individuals. They appear as horizontal and evenly spaced lines beneath the pleural line. B lines are vertical cometail artifacts from the pleural line. They appear like a flash of light extending down. A healthy individual may have 0 to 2 B lines in the intercostal space, but above that is considered abnormal and is often termed as a lung rocket. B lines, however, are important in this topic as B lines rule out pneumothorax. When air fills the pleural space, the normal lung sliding is no longer apparent, as demonstrated here. Importantly, however, the absence of lung sliding is not diagnostic of a pneumothorax. Some may also use M-mode at this point to look for the barcode or stratosphere sign, but I personally don't find this particularly useful. So now, let's say we have an individual with no lung sliding and a fitting clinical context for a pneumothorax. We have a high suspicion on the ultrasound for a pneumothorax, but it's not completely diagnostic at this point. We need to investigate other intercostal spaces, and our search is now for the lung point. The lung point is the interface between a normal lung and a pneumothorax. Here we can see both lung sliding and no lung sliding in the same view, and this is the lung point. The lung point is perhaps easier to comprehend when you visualize it on a CT scan, where you can appreciate the interface between the normal lung and the pneumothorax a bit better. Once we have visualized both the absence of lung sliding and the lung point, we can safely make the diagnosis of a pneumothorax on ultrasound. Note, however, that while ultrasound is useful for the diagnosis, it is quite difficult to appreciate the extent of the pneumothorax, so further imaging is generally advised. Finally, I would like to mention two pitfalls to avoid, and these are termed the E and Z lines. E lines are vertical lines from the subcutaneous air, but unlike B lines, they do not move with breathing. Z lines are common artifacts. These are vertical, bundle-shaped with no pathologic etiology. They are seen from the pleural line and they do not move with lung sliding, and they do not erase A lines. I hope you found this lecture helpful, and if you would like more content, including flowcharts, I would recommend to check the Instagram page, which is linked below. Thank you for listening and have a great day.